will be focused, today my presentation will be focused on ADHD, and I'm going to talk about like how ADHD is different for patients with autism with a focus in pediatrics. So I love to show this slide. This is a patient, this is related to a patient of mine that at 5 years of age was diagnosed to have ADHD, and he also had a prior diagnosis of mild high functioning autism. So at 5 years of age, he had a diagnosis of ADHD, and he was not really taking advantage of his therapies as well. He was in a therapeutic program in a private therapeutic preschool or kindergarten, and he was not really taking advantage of his services. And so we diagnosed him with ADHD. The main symptom was hyperactive and impulsive, but he was also inattentive. So we decided to treat him with a second-line drug for ADHD called guanfacine, G-U-A-N-F, like Frank, A-C-I-N-E. And that's a medication that does a good job controlling the hyperactivity and impulsivity. And he did so much better with that medication. His behavioral challenges diminished quite a bit, and he did well for about a year. But then the next year, he was going to an inclusion program in a public school, and he was not really making a lot of progress. There were a lot of reports that he was distracted, and he was not really focusing in his work, and he was not making the progress that everybody expected he could make academically. So we started him on stimulant medication, a small dose of stimulant medication at 6 years of age, and he responded really nicely to this stimulant medication, and he did so much better in his program. So his father is a teacher, and he likes art, so he had this child like copying a scenery picture in different stages of this process. So the picture number one was copying this picture was from copying the scenery picture without any medication before he started any treatment when he was 5. And then the picture number 2 was with the guanfacine, which does a good job with hyperactivity and impulsivity, but is not doesn't have a direct effect on attention. So he had a much nicer copy of the scenery picture, but it's still far from it. And then you can see number 3 and number 4, he did copy these pictures when he was on the stimulant medication, and you can see how like the level of detail that he put on this. And I think this is a very nice way of illustrate how ADHD can have an impact in the functioning of children with or without autism. And by treating effectively this condition, we can help these kids improve quite a bit. So, okay, so let's talk a little bit about ADHD. ADHD is the most common neurobehavioral condition among children. The range in the literature for prevalence of ADHD is 4 to 12, and there's 3 to 6 in adults. And there are 3 types of ADHD. There's the predominantly hyperactive impulsive. There's the only inattentive type, predominantly inattentive type, and there's the combined, which is the bulk of patients with ADHD. The majority of patients with ADHD have the hyperactivity impulsivity component and also the attention component. I want to say that this predominantly hyperactive impulsive type is mostly for younger children when it is hard to measure attention. In reality, ADHD is a condition that affects attention in everybody. The big differentiation is that if it also causes hyperactivity and impulsivity, or if it only affects attention. This is a condition that affects males significantly more than females, like many other neurodevelopmental conditions. If you look at the combined type ADHD with a component of hyperactivity and impulsivity, the ratio of males to females is 5 to 1. But if you just look at the inattentive type ADHD, the ratio of males to females is much lower. So females have a much more robust presentation with the inattentive type compared to the hyperactive impulsive type. But there are still a lot of girls that have the combined type ADHD. So this slide is trying to show the biological, the anatomical substrate of ADHD. So these are the main organs that have been associated with the pathophysiology of ADHD. The corpus callosum, which connects the left and right hemispheres, the basal ganglia, that has an important role in mood regulation and impulse control. Sorry about that. The frontal lobe, that has to do with organization, time management, and decision making, and the cerebral vertex that connects the two cerebellum hemispheres. Gosh, I got something in my throat. Okay, hopefully. But something that is important is it's important to look at the connections between the different areas of the brain. These networks have an important role in ADHD. So what causes ADHD? We don't know for sure what causes ADHD. Only 20 to 25% patients with ADHD have a diagnosis, another diagnosis that can be associated with an organic cause of ADHD. There are some patients that have fetal alcohol syndrome or in utero exposure to substances like cocaine, nicotine, and lead, or any insult to the brain, like trauma, infection, or hypoxia during birth, can lead to central nervous system damage and result in the ADHD symptom complex. So that's 20 to 25%. In 75 to 80%, the cause seems to be associated with a polygenic. There are many genes that seem to have association with ADHD. And there's high heritability that has been demonstrated with ADHD in twin studies that estimates the heritability to be 50%, which is significant, but it's not as high as autism. In autism, the heritability is 70 to 90%, but in ADHD it's 50%. But still, you know, many patients have a history of some of the parents or other relatives that have ADHD. So it's important to think about the natural history of ADHD. 70 to 80% of children with ADHD continue to have difficulties through adolescent and adulthood. So 75% from childhood into adolescence and 50% persistence from childhood into adulthood. Many times parents ask when we break the news about ADHD, so does that mean that my child is always going to have to take medication treatment for ADHD? And the answer is no. A lot of them do need to have some treatment for ADHD throughout their lives, but there are many that outgrow ADHD into adolescence and into adulthood. Something that is really important to be aware of is that the symptoms change through the child's lifetime. So for the patients that have the combined type of ADHD with a hyperactive impulsive component, the hyperactive impulsive components tend to fade by middle school. Like usually it goes up into elementary school, but many kids that are in elementary school, they stop being that hyperactive and impulsive. But the inattentive symptoms become more prominent and more apparent as the school demands increase. Something also that is really important to keep in mind is, and I'm going to show another slide with this, is that ADHD is associated with high frequency of psychiatric comorbidity. A lot of patients with ADHD have anxiety, depression, obsessive compulsive disorder, bipolar disorder. So it's important to be aware that some patients are diagnosed to have ADHD early on, and as they grow older, even in adulthood, these psychiatric comorbidities may come up. ADHD is a condition that is going to impact different areas of functioning. Early in age, one of the first things that we see an impact on is behavior and emotional regulation, but it can also have an impact in academic performance, inability to take advantage of services in patients with autism, it can have an impact on socialization and even in like adaptive skills. So in preschoolers, when we think about ADHD in preschoolers, usually they call the attention of parents and clinicians first because of behavioral disturbance. But once you go into the childhood, the impact is behavioral disturbance. There's also academic achievement, relationship with peers, and also self-esteem issues. That's something that is really important to keep in mind. People that have ADHD are aware that they are not performing at their capacity, and that takes a toll on their self-esteem. In adolescents, we see more, in addition to the underachievement, academically, self-esteem issues, we start seeing more legal issues, smoking, motor vehicle accidents, substance abuse, particularly we see this more in neurotypical patients, but we can also see that in patients that have autism spectrum disorders. And the impact of ADHD continues during college age with substance abuse, injuries, in addition to the others that we already mentioned. And in adults that have ADHD don't have like autism, they tend to have self-esteem issues, like psychiatric comorbidities, relationship problems, injuries and accidents, and occupational failure. So this information is more related to neurotypical people, but like I mentioned, in autism patients, it also takes an important toll and can affect their overall functioning and make them prone to self-esteem and also other psychiatric comorbidities. So this is a slide for like is cross-sectional, a population-based cross-sectional study that looks at neurotypical people, males and females with and without ADHD. So the orange here is females with ADHD versus females with ADHD without ADHD. You can see the big gap in terms of prevalence of substance use disorder, and also in males, it's even wider. There's also a big gap between people with ADHD and without ADHD with depression. The gap is a little smaller with bipolar disorder, but seems larger with anxiety. And we even have two conditions that are not psychiatric comorbidities, are metabolic conditions, type 2 diabetes and hypertension, that are associated with lifestyle. So you can see how the people with ADHD have a little more risk for or unhealthy lifestyle, and that makes them more prone to have these metabolic conditions. And we don't have these data in patients with autism, but I am sure that in patients with autism that have ADHD, there's a higher prevalence of these psychiatric comorbidities. Maybe not as much substance use disorder, but the others, I would say for sure. So how do we diagnose ADHD? DSM-5, the Diagnostic and Statistics Manual of Mental Health Diagnosis, has criteria for autism, and I believe people that are involved in the care of patients with autism are familiar with the DSM-5 criteria for the diagnosis of autism. But then there's also criteria for ADHD. So there are 9 symptoms of inattention that need to be present in patients with ADHD. In order to meet criteria, there need to be 6 out of the 9. And for hyperactivity and impulsivity, they need to be often in 6 out of the 9 criteria for hyperactivity and impulsivity. And an individual needs 6, this is more for children and adolescents, they need 6 out of 9 symptoms from either of both categories. So you need 6 out of 9 for hyperactivity, impulsivity, or inattentive, or both. The symptoms need to be present before age 12, and the symptoms need to occur in more than one setting. If they happen only at home or at school, the clinician needs to look for if there's something else, and these symptoms need to interfere or reduce the quality of social, academic, or occupational functioning. and should not be explained by something else. Something to keep in mind, and I'm going to talk more about this, is not every hyperactive impulsive individual, not every inattentive individual has ADHD. So it's really important for a clinician to think about a differential diagnosis, as there are other conditions that may cause those symptoms. And it's really important to go through this exercise when we are diagnosing a patient. An individual with inattention is an individual that can go under the radar if this individual has only inattention. Is an individual that has a difficult time paying attention to details, makes careless mistakes, has a short attention span for what is expected for their developmental age, seems to have a hard time listening, and very importantly, they have a tendency to fail to finish tasks. They tend to leave tasks unfinished, have difficulty organizing. People with inattentive type ADHD are often disorganized, but not always. And something that is really important is they have a hard time with tasks that require sustained effort, or tasks that are perceived as hard or even as boring. And they tend to lose things, are easily distracted, and are forgetful in daily activities. Something that comes often when I talk to parents about inattention in ADHD is they say, there's no way my kid has ADHD because my kid can read books for an hour, or my kid can draw for a long time without getting distracted. And I sometimes think that inattentive, like ADHD, is almost like a misnomer, because it's attention deficit hyperactivity disorder. It almost sounds like the individuals that suffer from this condition cannot pay attention, cannot regulate their behavior. But people with ADHD can pay attention, and people with ADHD can regulate their behavior and not being hyperactive and impulsive in some circumstances. But in order to do that, they need to be highly motivated. So if somebody is highly motivated with reading and loves reading, they're gonna read forever. If somebody is highly motivated by math and love doing math, they can be focused even in doing math work, even if they have ADHD. So I almost sometimes think that this should be called an attention behavior regulation disorder, where they have a hard time focusing attention or regulating behavior when they are not motivated. But when they are motivated, they seem to hyper-focus on these things. So it's actually the opposite. So people that have hyperactivity and impulsivity ADHD, you see them. So you don't need to study them too much. You can just get the report from school and from parents, and you know that these are people that are nonstop, moving constantly beyond what you would expect for a child at their developmental age. They cannot sit still in a meal. They cannot sit still in the classroom. They are running, climbing often. They are often loud. They talk a lot, and they are very impulsive. They blurt out answers. They interrupt others. They have difficulty waiting for their turn. So so hyperactivity, impulsivity is easy to see. And many times I have patients with autism, and sometimes we worry about, how complicated it is to give a second diagnosis to a patient that has autism. But if a patient with autism has the ADHD hyperactive type, you see these kids, and everybody sees them, that they are moving nonstop. So it's not really that hard to diagnose the hyperactive impulsive type ADHD or the combined type ADHD. What is hard is to diagnose the inattentive type ADHD, because those are individuals that just have a hard time paying attention, but they are not moving constantly. So in that case, if the patient has autism and you suspect that on top of the autism, they have an attention disorder, because there are so many overlapping symptoms between autism and inattentive type ADHD, that I feel that it's hard to diagnose for a clinician that sees these patients like for me, that I see them for a 1 hour intake, or I see them like for half-hour follow-up visits. So for those patients, I feel that we often need to have a psychological evaluation, try to understand, well, how do they work? get input from the teachers, particularly for special ed teachers that know patients with ADHD, because those teachers are in a position to tease out better if a patient with autism has inattention or if a patient with autism just has autism. So, so I was talking how every time we are diagnosing somebody with somebody that has ADHD in general, we need to think about other conditions that could explain hyperactivity, impulsivity, and inattention. So there are medical conditions that need to be investigated. Most of the time, just with a history. Most of the time, we don't need to do a lot of medical workup to diagnose ADHD. Like if there's a sleep disorder, maybe if there's a sleep disorder, you may want to do a sleep study. Or if you suspect seizures, you may want to do an ADHD to make sure. But beyond that, you don't do a lot of tests. For thyroid disorders, hyperthyroidism can look a little bit like hyperactive ADHD, and hypothyroidism can look like inattentive type ADHD. But usually in those cases, there are other symptoms that make us think about thyroid disorders, not just the ADHD symptoms. Traumatic brain injury, a history of traumatic brain injury should make us think about that being the cause of the inattention or the executive function challenges. Medications, we should never forget that there are many medications that can make kids tired or inattentive or hyperactive and impulsive. So for us, it's always important to look into that. And sometimes we get into sophisticated genetic or imaging studies, and we forget the basics. You know, every time we have a patient that has a neurodevelopmental disorder, we need to make sure that vision and hearing are okay before giving another diagnosis. So in terms of psychological conditions that can look like ADHD, this is a little trickier because these psychological conditions can be a differential diagnosis. So for instance, I have patients that come with anxiety and with symptoms of inattention. And I kind of ask myself, is this primarily anxiety or is this primarily an attention disorder? And I have symptoms for both. So that's a common differential actually when I see patients with ADHD, like which of these is. And so you try to get a history, and when you have the hyperactivity impulsivity component that is documented in more than one setting, you can tell that that's one of the problems, that's ADHD. But many times ADHD comes with anxiety. So this is really important to tease out, is one or the other, but it can be both. And same with depression. Depression can look particularly like inattentive type ADHD. And so it's really important. Something that helps tease them out is the history of the symptoms. If the mood symptoms correlate the history of inattention over the years. We also have oppositional defiant disorder, conduct disorder, intermittent explosive disorder that need to be considered. And sometimes these conditions are companions of ADHD. Obsessive compulsive disorder is also an important condition. Autism, like all of this, is a condition that needs to be thought when you are evaluating a patient with ADHD. But like we are talking today, at least 30 to 50% of patients with autism also have ADHD. So these are not exclusionary, and like a clinician should think about one or the other, or both. For adolescents and young adults, you need to think about substance use disorder and thought disorder, psychosis. These in pediatrics are uncommon, but they can present. And early on, they can present a little bit like ADHD. And post-traumatic stress disorder is, such a complex condition. I have a lot of patients with post-traumatic stress disorder that seem to have symptoms of ADHD. And it's so hard because the emotional, try to tease out the emotional trauma. Maybe a lot of these kids are exposed to drugs in utero, and then they have symptoms of ADHD, and try to tease out these conditions is so difficult. And sometimes you come with a conclusion that they have ADHD, but then when you treat the ADHD, they don't respond well to these medications. So it's post-traumatic stress disorder is, we could have more than an hour talking about this condition, and it's such a complex condition. Something that is really important to consider when evaluating a patient with ADHD is this child having the right classroom placement. I find that so important. Because if a child, particularly if a child has autism or other neurodevelopmental disorder, is not in the right classroom placement, it's hard to know if the child is inattentive or hyperactive impulsive because of ADHD, or because the child is just out of their element, asked to sit in a place where he doesn't have a clue of what's going on. And that applies for patients that have intellectual disabilities, learning disorders, language processing issues, speech language disorders, or other neuropsychological conditions. So I always think in order to evaluate that child, you ideally want that child placed in the right environment, particularly if you want to know if you can rely on the information from the educators. So like I mentioned before, a lot of the differential can also be comorbidities to ADHD. Actually, having a neurodevelopmental disorder makes people more prone to have another neurodevelopmental disorder. So a lot of our patients with autism and ADHD also have sleep disorders, anxiety, depression, oppositional defiant disorder, obsessive compulsive disorder, and you need to try to kind of integrate all these conditions. And okay, I don't know if we have any questions or comments.
We have some that have come through, but I think they are likely better served for the panel discussion at the end so far.
Okay, thank you. So now I'm going to give a perspective of the common co-occurring conditions with autism. So I was talking a lot about ADHD from the ADHD perspective. Now I'm going to talk more about the autism perspective. So these are the common developmental co-occurring conditions with autism: intellectual disability, language disorder, tic disorders, motor abnormalities, and ADHD. So ADHD is considered here like a developmental condition. And you can see the ADHD is probably, among the highest comorbidities, developmental comorbidities for autism. So ADHD is highly comorbid in children and adolescents with autism, and should be screened for in all youth with autism spectrum disorders. The higher the severity of autism, the higher the chance of other comorbidities, like psychiatry disorders or developmental disorders. The co-occurrence of ADHD and autism is associated with worse functioning and additional psychiatric symptoms. So the differential diagnosis of ADHD and autism is more complex. So these are the common psychiatric occurring conditions with autism. So we have anxiety. Anxiety is the most frequent. A lot of patients with autism have anxiety. Depression is also like a high prevalence comorbidity, and tends to come up more in adolescents, but can be present, adolescents and adults, but can be present at any age. We have OCD, substance use disorders. It's not as common, but it's there. There can be psychotic disorders, oppositional defiant disorders, and eating disorders. So this is the context where we see ADHD. And this is, this slide tries to give you like a kind of overview of the overlapping of these conditions, like ADHD and ODD, oppositional defiant disorder, and any anxiety disorder. So you can see how there are so many patients that have these three conditions, and there are many patients that have ADHD and anxiety, or there are a lot that have a lot of the patients with oppositional defiant disorder have both, have anxiety and ADHD. So there are not that many that don't have these conditions. So whenever we see significant behavioral problems, we need to think, in patients with autism, we need to think about ADHD and anxiety. So anxiety is common across all age groups with autism. The most common are social anxiety disorder and generalized anxiety disorder. And somehow high functioning individuals tend to be more susceptible, but not just the high functioning, but they seem to have like a higher prevalence. And that's something that is going to be pervasive when we are working with patients that have autism and ADHD, anxiety. So I want to talk a little bit about ADHD management. So ADHD cannot be managed just like medication. If a clinician just tries to do medication, cannot do a good job. So we need to understand, we need to educate parents on what's ADHD in their autism patient and how to address it. We need to think about how to support this child at school, link to therapeutic and community supports, and try to get like a behavioral modification program. And parent training is the best studied and validated program for addressing ADHD. So it's really important when we do medication management and the other management, specify appropriate target outcomes in various domains of functioning. And we need to do like a systematic follow-up. You know, you cannot prescribe medication to a patient with autism and ADHD and see them in 6 months. So they need a little closer follow-up. So in this context, talking about medication for ADHD, stimulants are the best medications to treat ADHD. The effect size is considered 1.0, and there's no other medication type that comes close in the treatment of ADHD. Stimulants are the best. And this is a study with neurotypical elementary school students. These were more than 500 students that were followed over 14 months in this classic study called the MTA in the 90s. And they were distributed in 5 arms. So the pink arm was, they were receiving combined treatment. They were receiving stimulants and intense behavioral modification treatment. And they were the ones that did the best. But the light green group got only stimulants, and they did very close. And in the long run, there's no really difference between the medication management and the behavioral intervention plus medication. And then we have the orange group that is just behavioral intervention, which is, you know, is kind of far from the medication group. So one of the big conclusions of this study was that the medication management is really the game changer for patients that have ADHD, neurotypical patients with ADHD. The other important conclusion was that, you know, these are, the gray is the community care docs managing these patients versus the psychiatrists or physicians that specialize in treating ADHD. So there's a big difference between the care that is provided by community care physicians and specialists. And that's because sometimes the community care physicians stay too low in the dose and don't titrate enough the medication to get the full benefit from it. So this is kind of like a complicated slide, but so this is a synopsis, and the big neurotransmitters that are relevant for ADHD are dopamine and noradrenaline. And what the stimulant does is, what the stimulant is gonna do is gonna prevent the reuptake, like the resorption of the dopamine. So there's gonna be more dopamine in the synapses, and there's going to be more effective transmission between the neurons that have to do with attention, hyperactivity, and impulsivity. So, so that's the reason this medication is called stimulant, because it's not going to stimulate the patient, because it actually makes the patient kind of slow down and more focused. but it's because it's going to stimulate the transmission in the synapses in the areas that have to do with executive function. So I just want to do a quick slide on like making a point. There are two big families of stimulants. There are the Ritalins or the methylphenidates, and there are the amphetamines or the Adderalls. So these are two different families that have similar mechanisms, but they work different in different people. It's a little bit like a lot of people can relate if I give the analogy with Claritin and Zyrtec. We all know these antihistaminics, and some people do great on the Claritin, and some people do great on the Zyrtec, but the reverse is not always the case. And they have similar mechanisms, but they work better in some people and not that well in other people. And the same happens with methylphenidates and amphetamines. Some people do better with one, and some people do better with the other. There are others that do fine with both, and there are a few that don't respond to any of them, but they're just 10 to 20%. So what clinicians we do is we prescribe one of them, and if one family doesn't work, we still have the chance to go to the other family, and there's a good chance if the diagnosis is correct that the other family will work. And this is just so you have an idea how we think. There are, in the methylphenidate family, there are like 4-hour action drugs, there are 8-hour action drugs, and there are 12-hour action drugs that we can use. And some people respond better to one or the other. Usually for the younger kids, I like to do the short acting. They seem to do better with the short acting, but if I have an adult or a like high schooler that has a lot of homework, I may want to do the 12-hour product. And for the elementary school kids, sometimes the 8-hour product is enough because they often don't have a lot of homework. And we have a similar, this should say amphetamine class drugs. This is a typo, but in amphetamine class drugs, we have Vyvanse, Adderall XR, and Adderall immediate release. So stimulants can have side effects, and there's a list of side effects here. I'm not gonna go through all the list, but I wanna tell you, the majority of people don't have the side effects. The majority of people just get the positive effects. And the big side effect is the decreased appetite. So we need to keep an eye on weight and growth. But that's the reason you have a physician managing your medication to address that. Sleep difficulties are common. But something that parents worry a lot about is changing the personality of their child with these medications. And that's something that can happen. You can have irritability, emotionality, and dullness. And somehow these symptoms tend to happen more often in patients with autism. But what I tell parents in this case is, yes, this medication has the potential to change your child's personality. But if we see that this medication changes your child's personality, we can just pull the plug and stop the medication and nothing happened. But we don't have to keep your child with a different personality. We don't want to change your child's personality. We can then try something else and see if your child can benefit from something else without changing his or her personality. So that's a message that I give to them. I also tell them all these side effects are if you stop the medication, they are reversible. So you don't have to worry about long-term side effects. These side effects are not life-threatening. And there's a lot of myths about these medications causing substance use disorders, and that's totally not true. These medications are not addictive. But I tell parents that it's worth to try this small risk for side effects if your child gets to find a medication that allows to pay more attention and to be able to take better advantage of therapies and services, and be able to take more advantage also the special education services. So this is a slide from a publication that demonstrates that ADHD medication doesn't increase the risk of substance-related problems. So these are the medications that we can use for ADHD, but again, the best ones are stimulants. Strattera or atomoxetine can be a good one. A medication that I like to use, particularly for younger children, are the alpha agonists, guanfacine and clonidine. These medications are non-stimulant and are really good for hyperactivity, impulsivity, and emotional regulation, but don't help directly with attention. If I have a young kid, a 5 or a 6, that is very hyperactive, and I give this medication, they slow down, they are better regulated, and because they slow down, they can pay more attention and do more work. But eventually, they are gonna need a stimulant that tackles attention directly. But when they are young, you don't need a lot of attention. But when they are older, they would need like a stimulant. Behavioral therapy is really important. We always recommend behavioral therapy for patients with autism. And these are the like the evidence-based programs for parenting behavioral training. So I like to talk about preschoolers. I do a lot of preschoolers in my practice. And I just wanna give an overview of this PATS study. They did a study with 300 children over 5 weeks for efficacy, and they follow these kids for 40 weeks. And these were preschoolers, so under 6 years of age with a diagnosis of ADHD. And they got into this intensive behavioral program. And then the ones that didn't respond to the intensive behavioral program were placed on stimulant medication. The conclusions of this study were that just doing behavioral interventions in preschoolers help address the bulk of their problems in 1/3 of them. So 1/3 of these ADHD kids that came to for help because of their ADHD, probably because they had some disruptive behaviors, didn't need any medication because behavioral therapy was enough, at least for the time being until they were in school age. And then for the remaining 200 patients, when they were treated with stimulants, particularly with Ritalin or methylphenidate, a lot of them, they did better. But preschoolers didn't have as good of a response as elementary school kids. And they had a little more frequency of side effects. So so this is an important landmark study for preschoolers. So you do behavioral therapy, you can try stimulants, but beware that it can cause, it's not as efficacious, but still the majority of kids take advantage of it, and there's a little more risk for side effects. So these are clonidine and guanfacine. I already talked a little bit about that. So I wanted to show you our clinic experience, because we collected our experience over 6 years of preschool children with ADHD. And these were the age groups from 41 to 54 months, 54 to 60 months. So we had them evenly distributed from a little bit less than 2 years of age to 6 years of age in 4 groups. And all of them had at least one comorbidity. They had disruptive behaviors, 44%, global developmental delay, 24%, mood dysregulation, 14%, and 32% of our 150 patients had autism and ADHD. So I'm going to talk about these 50 patients that we saw over these 6 years that had autism and ADHD. So let me see. So I'm going to go straight to the patients, preschoolers with and without autism. So I have learned that because these patients, like younger kids, having a young age, being a preschooler gives you more risk for having side effects when you have methylphenidate. And we also learned that having autism gives you more risk for having side effects to stimulants. So in my experience, I found that a lot of the 4- or 5-year-olds, when they were with autism and ADHD, when we gave them stimulants, they didn't do that well. So I started trying guanfacine, which is a second-line ADHD medication for hyperactivity and impulsivity. And what I found is, and I offer both options to my patients, and I found that 2/3 of all the patients with autism and ADHD that were treated with methylphenidate responded favorably. And 2/3 of the patients that were treated with guanfacine also responded favorably. So I learned that, you know, these two medications are equally efficacious for patients with autism and ADHD. So I thought that was a pretty cool finding. And then I checked for side effects. This is a kind of like a busy. I'm gonna try to walk you through this. So the purple and the red are the patients. The purple are patients with guanfacine, ADHD and autism, and the green are just ADHD. So what I want to show you is that the big side effect of guanfacine is tiredness. And what I found is that the tiredness in all the patients with ADHD was the same than the patients with autism and ADHD, which is 1/3 of them got tired on the guanfacine, which is a big number. But then there are 2/3 that don't get that tired. But something I thought was interesting is in the red one, these are patients exposed to methylphenidate, to Ritalin. These are patients with Ritalin on patients with autism and ADHD. And the blue is just patients with ADHD and including autism. So the irritability was much higher when you try the methylphenidate in patients with autism and ADHD than in patients with ADHD, period. So there's like a high side effect of irritability and emotional ability in patients that have ADHD and autism when you try the Ritalin. But the guanfacine seems to have the same side effects regardless. So my conclusion from this study was guanfacine is a good medication for young patients that have autism and ADHD that may have risk for tolerating the Ritalin at that young age. Eventually, when kids are 7 or 8, I do try the stimulants, but when they are younger, guanfacine seems to take the edge out of them and makes them more available for therapies. So, okay, so ADHD is a very prevalent condition in children with autism. ADHD in children with autism can lead to disruptive behaviors, emotional dysregulation, and learning difficulties. Children with autism have a higher risk than non-autism children to present side effects to stimulants. They don't have increased risk for side effects to Clonidine and guanfacine. So that's it. And I have to go really quickly to tell you about Spark now. Right, Holly?
Maybe if you just want to spend maybe 2 or 3 minutes giving an overview, I want to make sure we have time to answer some of the questions that have come through. So if you, everybody will get these slides, so they'll be able to go through. If you want to kind of go to the last slide for Spark and just kind of give that overview of what it is and why, I guess why we're talking about that today and why families might want to participate.
Yeah. So Spark is a nationwide study that is done in, the last time I read about it, it was 26 centers that specialize in doing working with autism patients across the country. And the goal is to collect saliva samples from families, parents, biological parents, and children for 50,000 of these families. And by what they do in these studies, they do an advanced genetic study called exome sequencing to try to identify a genetic variant that is causing this child's autism. We know that 80–85% of autism is genetic, caused by a genetic variant, but we don't understand. It's a very complex genetic process. There are more than 400 genes that are expected to be causing autism. So it's very complex. And this landmark study is aiming to understand better And the importance of understanding better the genetic causes of autism is that once we understand them, we're going to be in a position to, once we understand the causes for autism, we can design targeted brain treatments for this condition of autism. So we really encourage families to participate. On one hand, they can get a result and get an explanation of what is causing their child's autism in 10, 20% of cases. But I think more importantly, by participating in this study, is that they are contributing to the advancement of the understanding of the causes of autism, which will lead to treatments sooner. And also by participating in Spark, they join this nationwide research community for autism. And there will be opportunities down the road where one of these centers may offer, if your child qualifies for a study, you may be invited to participate, which you can always say, thank you, but no thank you. But maybe there will be a study where you say, maybe I want to try this research study for my child. So that's a little bit about that. And let us know if you have any additional questions. Okay, so we're ready for discussion.
Yeah. I will go ahead and Betsy and Rose, feel free to join us with your cameras, and Cesar, feel free to stop screen sharing if you'd like.
Yep.
Again, we will send out the slides afterwards so everyone can see them and review and look through if they would like. But yeah, I think maybe the first question to start with would be, we had a question asking you to speak a little bit more on the differences in manifestation in ASD and ADHD between boys versus girls. And so if you could speak to that a little bit, I think that would be great.
Sure. In general, in autism, girls, as a group, girls tend to have like a milder presentation of autism, and they tend to be a little more have milder phenotypes of autism as a group. There are some girls that have more severe, and there are also many boys that have milder forms of phenotypic forms of autism. And same with ADHD, like many girls can have as a group, like a milder presentation of ADHD. Comparatively, there's a higher proportion of girls that have inattentive ADHD compared to boys. So there are a lot of girls that present just with inattention. And in general, patients that present with inattention are harder to tease out, because particularly if you have a mild form of autism and a mild attention disorder, it can go under the radar. You may think, and it can be masked by anxiety many times. It can be masked by other like behavioral, emotional regulation difficulties. It may show up just with like social anxiety, or maybe some academic difficulties, or many other symptoms. So it's really important to think about this condition, but it's hard to diagnose it just by a clinician that just eyeballs, or by a teacher. I think these patients need to have, when you have a female with a diagnosis of autism, I think it's important to do a neuropsychological evaluation. But I'm not saying that all the girls that have autism should have a neuropsychological evaluation, but if you feel that there are some struggles, stresses that many of them may have, I think the best way to look into it by doing a neuropsychological evaluation that is going to look at the like cognitive profile, is going to look at the academic abilities, and it's going to look at like comorbidities, mental health comorbidities, kind of interviewing, getting input from different people, clinicians, school that work with this particular individual. So that could allow all this data could help us tease out this complex problem.
I think on that note of psychological evaluations or neuropsych evaluations, we had a participant share that their daughter was diagnosed with autism just very recently. And I'm sure a position many families and parents can relate to, but not quite knowing where to start. And so I think hearing from multiple people on this question might be helpful, but Dr. Ochoa, we'll start with you. Do you have recommendations on where a parent with a new diagnosis of autism might start, who has already been in early intervention for a year and was recommended to start with ABA therapy, but really just questions on where to start?
You mean where to start?
In terms of after a diagnosis, what would be some of the priorities that you as a developmental and behavioral pediatrician would recommend for a parent of a 2-year-old after a new diagnosis?
A 2-year-old. So I would probably try to, I think, talking to your developmental behavioral pediatrician to discuss, I think this is an important, a big conversation. We have a long conversation with families once there's a diagnosis, and there are different options. And I think one of the options that comes to mind is if it's a 2-year-old, early intervention services are so important, and they are home-based and family-centered. I feel early intervention is such an important program. But also, there are centers that provide additional services because you want intense services and insurance. Insurance is an important factor here, but if insurance allows, you can try to expand those services and look for more intensity of services, targeting communication, with speech therapy, trying maybe increasing the frequency of speech therapy services, targeting sensory processing difficulties, emotional regulation. You can do that with occupational therapy, trying to work with a social worker, a licensed clinical social worker that has experience working with families, trying to get guidance on how to address, the different, the emotions first as a parent, how to address behavior in this child. Oftentimes, these children that have a diagnosis of autism have some behavioral challenges. Something that is interesting is ABA. ABA is out there, and I know that can be controversial. I personally believe that ABA can be helpful, but it's really important to see, I see ABA as a method of teaching. Kids can learn, young children can learn from ABA, but it's really important to pay attention. What are the treatment goals? What is it that you're trying to improve? And if there's ABA, there should be a focus on social communication skills and core communication skills, among other particular. But yeah, that's a big question. I'm sorry, I'm taking a little too long.
No, it's okay. And it is a big question. I think some of the key things I heard from you there that I'd like to echo is potentially working with a developmental pediatrician over time. So I think that's one recommendation and tip. I think working with clinicians to support and build skills. I think as a parent of a child, of a young child in particular, going and managing collaborations with several different therapy agencies can be really overwhelming. And so I think at times providing, especially if speech therapy, occupational therapy, behavior therapy is all recommended, potentially working with agencies that are able to offer that in one location. And I think really at 2 years old, you are the person that spends the most time with your child. And so working to find interventions that will teach you the skills on how to continue and enhance what the therapists are doing with your child at home. I think that would be one of the primary recommendations for kiddos that I would make for kiddos of parents of kiddos of really young kids. Just because, again, you spend the most time with your children. Rose, I don't know if you want to speak to some of your thoughts as well.
I think you guys covered it, but I did just want to add, I saw that they put DuPage County is where they're looking in particular. And I do know our Easterseals in DuPage County, which is separate from the Chicago location, has that kind of clinical services, early intervention, a lot of speech therapy, OT. So you may want to reach out to Easterseals DuPage. They definitely have those types of therapies at their locations.
Absolutely.
And I believe they also have, I have a great experience with Easterseals of like DuPage. And they, you know, I love everybody that has been referred there has great things to say. And at some point they had ABA. I think they still have ABA, right? Or not?
That's a great question. I'm not as familiar with theirs, but I do know they have speech and OT and some social groups and things like that. So I'm not positive about the ABA though.
And I will,
but yeah, they're a great group.
Yeah. And I will put this in the chat, but the Autism Resource Directory through the Autism Center at Rush provides free kind of resource navigation to families. And so for the parent that asked that question, I will put the website and the phone number in there as well. And you can get some kind of one-on-one assistance in navigating some of those resources. I think next question I'd like to pose first to you, Rose, but any tips on ensuring kind of proper school placement, thinking about kids who've been referred to therapeutic day schools and within the context of thinking about race restricted environment, any tips you might offer parents who are navigating that for the first time?
Definitely. So most therapeutic day schools, especially ours, we do have parents very involved in the intake process. Many parents, when their student or when their child gets referred to a therapeutic day placement, would start to tour facilities. I know many districts will send out referrals to different therapeutic day schools, but you can also be proactive in starting to look around yourself and kind of get out there and see what schools are like. And we're happy to help with those tours at Easterseals. If that's the type of placement that you're looking for or that the school's looking for. But in terms of just your child and making sure it's best for them, overall you want a place that they're striving to reintegrate the student, and Easterseals, that is one of our #1 goals, is to reintegrate a student back to their home district when they, and giving them the supports that they need to be successful there. Obviously there are some students that stay with us longer and some that may stay with us throughout their school career if necessary. And it's, hard to say, it's very individualized, but making sure that there's data. So when you go to those IEP meetings, that they're sharing the reasons why they're recommending a certain placement. And if you're not in agreement with that placement, that you're, potentially working with an advocate or just kind of looking into, asking those kinds of questions about the data and why they're recommending that, so that you can kind of see what the background is.
Absolutely. And I think the special education services really vary from school to school and district to district. So that choice is going to be really dependent on the services available. I'm going to transition to another question on here. Or one question that was posed is it common for children with autism and ADHD to be nonverbal? And then what's the likelihood or chances that speech therapy will make improvements in an individual's speech? And maybe we can start with you, Dr. Ochoa.
Yeah, many children with autism have communication delays. And there are a few that take much longer, that parents get really nervous. It's 3-4 years of age and there are not that many words. I have seen that somehow patients with autism sometimes take a little longer to speak. So what we recommend in those cases when, it's 3-4 years of age to start thinking about, first, of course, you want to check hearing function, and but once you have that assured that there's good hearing function, start thinking about augmentative communication approaches, like using signs, using pegs, using AAC devices, particularly if the receptive communication skills seem to be a little bit ahead. and try to get these kids, we feel that it's really important to, because if the words are not coming, try to use these other interventions to have the brain of these children think about communication. And I think sometimes for children with autism that are more visual than verbal, using a PECS or a device can help understand better the concept. And I have seen that sometimes parents are not as proactive in the use of it. It gets to be used more in the school setting. And sometimes parents sometimes think that, they want their kids to talk, not they use the cards or not to use the device. And I feel that it's important that these children get exposed across. And I recently had the experience of this family that I was able to finally get them to get on board with the augmentative communication device. And when they started using across the board in this 4-year-old, then it's almost like the child was really enjoying the communication and was using the device more consistently and making more progress. And then the words started coming up. And he started, it's almost like he understood, something clicked, and he understood the importance of communication. There's still sometimes some children that don't get to talk much as they grow old, but having a child with 4 or 5 years of age, if they have autism, sometimes they take a little longer to talk. But you cannot make a generalization. But if your child is taking long to talk, I will still work with a speech language pathology and try to use this alternative means of communication, because I feel that can be really helpful.
Absolutely. And I saw in the chat, there was a question about whether or not the ability to communicate can have an impact on anxiety and depression and overall mood with individuals with autism. And I think, I can speak to that just in terms of my own patient caseload, in that I think we've definitely seen that manifestation come at times. I don't know, Dr. Ochoa, if you can speak a little bit more to clinically, as a whole, can the ability for individuals to communicate and individuals with low verbal abilities present more commonly with anxiety and depression as a result of that?
Sometimes it's hard if the patients are not communicating how much is anxiety, depression, dysregulation, but definitely there's a higher frequency of behavioral and emotional regulation problems in individuals that cannot express what they want. If they have an intense temperament, that is not a good combination. So yeah, definitely the limited communication is a factor for frustration, for more behavioral challenges, and trying to work on offering the means to communicate in alternative ways can help a lot with those challenges.
Absolutely. And we know, working with individuals and clinicians to make progress and find the right fit for services takes time. And so we had one question early on related to recommendations for behavioral therapy programs. And I would say that I'll answer first and people can jump in, but in terms of specific behavioral therapy programs, it really depends on presentation and needs of your child, your family, and what it is that you'd be looking to really target within the scope of treatment. And so I would recommend calling our autism resource directory, calling the resources through Easterseals that Rose had suggested prior to really talk through with an autism specialist about the types of services, especially if an evaluation hasn't happened recently. If it has, then that evaluating clinician might be able to offer some insights as well on what might be best based on what your child is needing. I don't know if anyone else wants to speak to that as well. I'm going to pose another question here, and we are just wrapping up. So we'll get to one or two more questions here. Maybe we'll start with you, Dr. Ochoa. And then we'll jump to Betsey. Welcome back. What's your best advice for a teenager with a diagnosis of autism and ADHD, who, as the parent said, is low on the spectrum for social inability? And what's your recommendation in terms of from the social aspect and the pressures of explaining social differences? What are some of the treatments or services you would recommend?
For a teenager, trying to, the school program, a teenager should be in a school program and should have time with a social worker and have minutes with a social worker, both in ideally in a social skills group where they can promote socialization, and maybe some time for some, depending on where is this child in terms of communication and understanding, trying to talk about feelings, about and if differences. I think working with a social worker at school level and trying to find a counselor after school, which it depends a lot. What's the insurance? That becomes a little more tricky, but ideally finding a clinician that has a licensed clinical social worker or psychology degree that has experience working with adolescents that have different developmental abilities, and meeting on a regular basis to both try to address their emotional, their behavioral difficulties, and also trying to explain the social differences. And I guess that both working on trying to explain things, but also trying to teach on the spot with other youngsters. I think that's I think that's the most effective, teaching a group where they can really act what they are hearing.
I would agree. I think that's super important, Dr. Ochoa, the understanding component, along with the tools and strategies to effectively engage socially. Some of the rules and the norms and those things that come naturally to us need to be explicitly taught to young adults with autism and teenagers. And there are a lot of tools. I think next week's panel will actually get into some of those types of actual strategies, but there are a lot of really good programs that have been developed that are utilized by some of those professionals that Dr. Ochoa referenced. And I would just say too, as challenging as sometimes or anxiety provoking as it can be, getting out into the community and being in the community as much as possible and finding activities outside of school there's a lot of really good programs through park districts. Some are, inclusive, some are special rec. Doesn't need to be either. You also could just enroll in programs and work with your community. I know a lot of that depends on the community that you're in and who you know in the community, how comfortable you may be. But I do think that there's a tendency, because those social interactions don't go well, to isolate, and we want to avoid that as much as possible. So I think taking every opportunity, including those services and those specialized, social skills training, but also just getting out there and getting comfortable being in the community is extremely important.
Yeah, I think having opportunities to practice what you learn in those individual and group capacities is incredibly important. I think at that, we will wrap up. If any attendees have follow-up questions, feel free to reach out and let us know. Feel free to bring them back to part 2 next week. We will follow up with an email again with these slides, as well as some of the resources shared in the chat box and via the typed answers, just so everybody has them. Thank you all for joining us. Thank you, Rose. Thank you, Betsey, for joining the panel tonight, and Dr. Ochoa for sharing your expertise. We will see anybody who's able to join next Thursday. All right, for part 2.
Thank you. Bye-bye.
Take care.